Good morning, everyone. I would like to thank you for inviting me to give this talk. And as you can see here, the topic that I am going to present today is normal flow findings in hematolymphoid tissue. And you probably can see from this slide here that this talk will be presented again in a few days at the International Clinical Cytometry meeting. And with that, I would like to, if you don't mind, I am going to read the synopsis about myself that I read just to introduce myself. Um, my name is Cholada Curry. I'm from, I earned MD from Mahidol University in Bangkok, Thailand, and complete residency in pathology at Baylor College of Medicine in Houston, Texas. She specialized in hematopathology and cytopathology. Currently, Dr. Curry serves as an associate professor in the Department of Pathology and Immunology at Baylor College of Medicine. She also a medical director of flow cytometry and hematology at Texas Children's Hospital in Medical Center, Houston. Her clinical expertise includes pathology analysis of blood, bone marrow, and tissue sample for pediatric patients. She utilized flow cytometry analysis to diagnose hematopoietic disorders such as leukemia, lymphoma, and bone marrow failure syndromes. Beyond her professional pursuits, she enjoys spending time with her two teenagers. They really give me headache and engaging in exercise like swimming, tennis, and Pilates, interests that you may see reflected in her talk today. And with that, I am going to start by let's go over objective for today's talk. First, we are going to illustrate normal patterns of hematopoietic populations that are typically encountered in clinical flow cytometry analysis. Then we will discuss features of NK cells, B cells, T cells, and myeloid lineages, including their precursors. And last, we are going to identify abnormal cell population using knowledge of normal maturation pattern. In order to accomplish the objective above, we are going to divide this talk into 4 parts here. And in each part, we will illustrate by use case examples to illustrate normal and abnormal flow cytometry patterns of hematolymphoid tissue. As you can see here, we will go over mature cells, myeloid precursor, B cell precursor, T cell precursor, and maturation. With that, let's start with mature cells in peripheral blood. Our first case is 17-year-old male with history of ALPS or autoimmune lymphoproliferative syndrome. He also had chronic ITP with positive DAT, lymphadenopathy, and splenomegaly. Lymphocyte subset analysis was performed on peripheral blood, and as you can see here, typically the first initial gating of blood or bone marrow, we typically use CD45 versus site scatter because it allows us to identify many populations within complex specimen, particularly blood and bone marrow. In this case, example, because
Dr.
yes,
Chris, I think we are seeing Dr. Medeiros screen,
uh-oh,
right? Okay,
yes or no?
I think now it's good.
Okay, good.
That's my fault. It's my fault, Shad. I can't seem, I see your picture, but it's like a little tiny postage stamp. I'm trying to get the big picture and I hit the wrong button. I'm sorry.
No, it's no, that's okay. Is it good on everyone else's screen? I'm supposed to be small with slide in the middle.
I think you,
Am I the only one that, I was looking for the big picture like we normally get, and I don't see it. Am I doing something wrong?
we can see Dr. Carvey's PowerPoint very well, and she's a small person on the corner.
No, she's
and then
very
the
petite lady,
presentation.
of course. I'm not trying to make any suggestion otherwise. It's my fault. I'll figure it out, but I hope I don't hit another wrong button.
Oh, I think someone said in the chat that someone else is sharing the screen. Oh, it's good now. All right.
Thank you.
Are we good? Yes?
Yes, it's good. It's all
Okay.
right.
No problem. Let's moving on. So on CD45 versus site scatter, since this is lymphocyte subset analysis, therefore we are going to focus on the blue population here, which is lymphocyte analysis. On lymphocyte subset, we typically interrogate B cell, T cells, and NK cells. As shown here, we can identify B cell using CD20, T cell using CD3, and NK cell using CD16 plus 56 and negative for CD3. When we take a look further deep dive into B cells, we can see that B cell markers are generally, we can use CD19, 20, and 22. And in general, B cell in peripheral blood lack CD5, CD10, and CD23. In normal or reactive condition, B cells should show polyclonal pattern by kappa and lambda, and as shown here, typically it's about 1 to 3 to 1, or ranging from 0.8 to 4. On NK cell accounting for about up to 5% of normal blood lymphocytes, and by morphology, it should have large granular lymphocyte morphology. There are two major subsets of NK cells. The first one is with the 56 bright and 16 negative. This subset of NK cell produce more cytokine with lower cytotoxic activities. On the other hand, the NK subset with CD56 dim and CD16 bright show higher cytotoxic effect through perforin and granzyme secretion. Next, let's move on to T cells. T cells are the majority of peripheral blood lymphocytes and accounting for about, with the CD4 to CD8 ratio of 1 to 3 to 1. So basically, they are predominantly CD4 positive in the peripheral blood. However, CD8 positive T cells can be expanded in viral infection post-transplant and in various malignancy. CD7 are lost in, as you can see here, usually we see the heterogeneous expression of CD7 with somewhat partial loss. And when that happens, it usually within the compartment of CD4 positive T cells. I would like to also talk briefly about alpha, beta, and gamma delta T cells. As shown here in this diagram, you can appreciate that alpha, beta are the majority of T cells in the peripheral organ. Alpha beta T cells are usually more than 90% of T cells in periphery, which include blood and lymphoid organ, and it's either CD4 or CD8 positive. This subset of T cells have diverse T cell receptor repertoire with adaptive immune response, which is more specific immune response. On the other hand, gamma delta T cells accounting for lesser number of T cells of about 5%. However, you can see higher frequency in gut mucosa, particularly small and large intestine. In contrast, gamma delta T cell receptor usually show CD3 bright with negative for CD4 and CD8. However, it can sometimes show CD8 positive but dimly. The T cell receptor repertoire is limited for this type of T cell, and typically they are associated with innate immune response. Back to briefly, I also would like to talk about double negative T cells. So double negative T cell usually, as the name implies, lack both CD4 and CD8. It can also further divided into two groups, alpha, beta, and gamma delta. The majority of the double negative T cells are actually gamma delta, whereas the minority of double negative T cells are alpha beta, and it is accounting for about 1% of peripheral blood and lymph node T cells. As you can see in these dot plots, when we get using the box here highlights double negative T cells, which compose of both gamma delta and alpha beta. The orange population are the double negative T cells. And then when we focus further on the double negative T cells that are alpha beta, we can see that in this particular patient, there are increased alpha beta subset more than 1%. Briefly about ALPS. ALPS are autoimmune lymphoproliferative syndrome. This is a rare hematologic disorder, and it is usually due to mutation in fast ligand pathway or programmed cell death. Usually because of the defective of lymphocyte apoptosis, and this can lead to lymphocytes changing in lymphocyte homeostasis, which then result in accumulation of lymphoid mass and persistence of autoreactive cells. Therefore, as you can see in our patient case example, patient can present with abnormal lymphoproliferation, including lymphadenopathy and splenomegaly. Autoimmunity can also occur, which result in cytopenias, and patient also can have increased risk of lymphoma. This diagram illustrates various clinical manifestations where patient can present it. So what about flow finding for ALPS? We can see that the expansion of alpha beta double negative T cells are usually the criteria for ALPS diagnosis. It is defined as more than 1.5% of total lymphocytes. And in our case example, we see that there are increased double negative alpha beta T cells of 2.3%. The criteria is also defined by using the proportion of T cells in which over 2.5% of T cells are defined as can be diagnosed as ALPS. And in our case, the patient have about 2.8%. Keep in mind that the diagnosis or criteria need to be in the setting of normal or elevated lymphocytes. Again, we can see that in our case, the double negative T cell for alpha beta are elevated at about 3%. So now I would like to invite you to participate in this quiz. But first of all, how are we going to do this? I hope you have the Zoom button that you can give some reaction. And we are going to do this by using the clapping, the first one as A, thumbs up as B, and smiley face as C. So with that, I'm going to read the question, and after that, I would love to hear some reaction. So regarding lymphocyte subset of peripheral blood, which of the following is not true? A, T cells are the majority of lymphocyte subset. B, expanded CD8 positive T cell may be seen in many reactive conditions. Or C, majority of double negative T cells are alpha beta positive T cells. With that, hang on, I'm not seeing reaction. Maybe I am hiding. Can someone just try to put some reaction so that way I know I can see it? I can see now. Oh, but then it's disappear. I was hoping to be like Instagram where the reaction is like, coming up from the bottom of the screen, but I could not see that. Anyway, I can see that the majority answer C, the majority of double negative T cells are alpha beta T cells. And hang on, need to come back. And this is an intended answer. the majority of double negative T cells, as previously discussed, are actually gamma delta positive T cells. This diagram somewhat illustrate and summarize what we had just discussed, in which we can see that the common lymphoid progenitor from the bone marrow will then go undergoing maturation in thymus. And with that highlighted here is each T cell will undergo either gamma delta or alpha beta selection. And as you can see on the bottom with the blue asterisk, the alpha beta T cells usually went into either CD4 or CD8 positive T cells and are associated with adaptive immune system, whereas the gamma delta are usually undergoing into be associated with innate immune system. Here is the second question. The aqua population shown here most likely represent A, reactive normal B cells, or B, lymphoma cells. The history is 56-year-old female with 1 centimeter right neck lymph node for 10 days. We are using the same reaction for A and B. So I should see either clap or thumbs up. Go ahead and put your answer in. I see some with thumbs up. Actually, hold up 1 second. Now I remember. Before I show you the answer, I would like to also briefly discuss about something. If you recall, we just talked earlier that B cell in peripheral blood generally lack CD5, CD10, and CD23. So briefly, why I am talking about CD5 expression in B cells now. Actually, there are some subset of B cell that expressing CD5 that can be identified in both mature and immature B cell compartment. And this can be seen in various body fluid. There are relatively increased proportions of CD5 positive B cells that can be encountered in certain reactive conditions. And it is important to differentiate from CD5 positive B cell neoplasm. This table illustrates how one can try to differentiate CD5 B cell from normal and neoplastic condition. So we are going to briefly talk about this. As you can see on the top is example from reactive sample, and the bottom is example from neoplastic. Regarding CD5 positive B cells, in normal condition, as you can see, once you see seamless transition from CD5 negative to CD5 positive. In contrast, on the bottom plot, you can see the discrete population of CD5 positive B cells. Next, when we take a look at CD20 expression, as you can see on the top, the intensity of CD20 are similar for both CD5 negative and positive B cells, whereas on the bottom, the CD5 positive B cells show dimmer expression. And lastly, once you see polyclonal pattern and also the expression that equivalent between CD5 positive and negative B cell as shown on the top. However, in neoplastic condition, one can see the expression that are dimmer. And in this case example on the bottom, it's actually a biclonal chronic lymphocytic leukemia / small lymphocytic lymphoma, or CLL/SLL. So back to our case example, now you can appreciate that CD5 show a very distinct population away from the normal, and also we see the lambda restriction. And therefore, in this example, can you please give me some reaction? I think we should all be able to answer this question quickly. Yes, I see a few with thumbs up. I will take it. Yes, this is a case of diffuse large B-cell lymphoma or B-cell lymphoma, or the final diagnosis is CD5 positive large B-cell lymphoma. To learn more about the mature cells in the peripheral blood in general, I would like to refer you to these educational resources from ICCS. Next, we are going to go over myeloid precursors and maturation. Here is our case number 2. 17-year-old Hispanic male with gum bleeding with purpura and ecchymosis. CBC show thrombocytopenia. Immunophenotyping was performed on the bone marrow, and you can see that there are increased abnormal population with increased size scatter. This population shows CD45 dimly positive but negative for CD34, 11B, and also show heterogeneous expression for CD117 and CD13. HLA-DR was negative, as well as CD15, which show low to absent expression pattern. By morphology, you probably already know the diagnosis. This is a classic abnormal promyelocytes where you can see the bilobe nuclei with intense granules. I would like to use this case to discuss neutrophil maturation. Here is a heat map of neutrophil differentiation. Although it seems quite complex, but if we understand the principle of the neutrophil differentiation, we can come back and dissect this heat map relatively well. First, I am going to talk about CD45. You can see that CD45 expressed throughout the stages of neutrophil maturation, as shown here in this dot plot, with increased intensity perhaps at the final stage of maturation. CD34 typically lost when the myeloid precursor mature into promyelocyte stage. However, CD117 is retained during promyelocyte and then lost afterward. Next, CD13 and CD33 are typically retained throughout the stages of neutrophil maturation. However, there are some change in intensity. As you can see here, CD13 show decreased expression during myelocyte stages. CD64, 15, and 11B, 11C, as well as CD16, shown here, mark the beginning of the stages of promyelocyte, myelocyte, and metamyelocyte maturation, respectively. And when we use the combination of CD13, which show decreased expression during myelocyte stage, and one of these markers most commonly used is CD16. As you can see on the bottom, when we plot CD16 versus CD13, we can see this allow us to identify the stages of neutrophil maturation. And as you can see here, people usually refer to this as Nike sign. Again, this is a case of acute promyelocytic leukemia with translocation 1517, and this subtype of leukemia accounting for about 5 to 15% of all leukemia cases. It is characterized by block in maturation at promyelocyte stage. The APL with translocation 1517 result from RA gene on chromosome 17 to PML gene on chromosome 15, which lead to PML-RA fusion. This type of leukemia have unique clinical presentation with DIC, in which our patient also have DIC. With the unique treatment of addition of atra and arsenic, patient typically do very well, and therefore it is important to make the correct diagnosis of this type of acute myeloid leukemia. By flow cytometry, we can see that this type of leukemia show high site scatter, and they should show expression of myeloid markers with CD13 and CD17 are somewhat heterogeneous, whereas CD33 and myeloperoxidase are strong and uniform. This should be negative for stem cells or early myeloid markers, including CD34 and HLA-DR. And as previously mentioned, this is the type of leukemia where the maturation is blocked at around stage of promyelocyte. Therefore, CD11b and 15 should be low to absent. The combination of morphology and immunophenotypic finding usually give clue to this type of diagnosis. However, definitive diagnosis require confirmatory tests such as FISH or PCR for this translocation or PML immunofluorescence. With that, I would like to again invite you to participate in this quiz. Regarding neutrophilic differentiation, which of the following is not true? A, promyelocyte express CD117, B, CD45, 13, and 33 are retained throughout maturation, or C, CD16 expression typically starts at around promyelocyte stage. Remember the question about CD117 and all these markers. I am going to give you some, refer you back to the diagram. 45, 34, 117, 13, 33. Pay attention to what the markers that mark the stages of beginning of the maturation. All right, please give me some reaction. I love it. A lot of smiley face. Thank you. Yes, and the choice C is an intended answer in which, so it's wrong for two reasons. We can see that it's not CD16 that expression, the CD that start, sorry, it's not the CD16 that start at the promyelocyte stage. For promyelocyte stage, this is CD15 that mark the promyelocyte stages, beginning of promyelocyte stage, whereas CD16 actually mark the beginning of metamyelocyte. Next, the red population, 5% shown here, most likely represent A, residual abnormal myeloblast, or B, normal myeloblast. For the clinical context, this is 11-year-old with acute myeloid leukemia. This is 1 month post-induction 1 evaluation. Before you go ahead and jump in the answer, I would like to also introduce you to another graph which will help us understand, hopefully even more, the neutrophilic differentiation. To correlate to our case example, I am going to focus on just the early stages of neutrophil maturation, as highlighted in these red arrows. We can see that CD34 and CD15, as highlighted here, will help us to identify normal myeloblast maturation. You can see that as the blast mature, this lost CD34 and start to gain CD15. Therefore, when we examine dot plots, we will expect it to see something that look like this. When we take another plot using CD117 and CD13, we can see that both of these antigens show synchronous gain as blast mature. Therefore, on the dot plots, we will expect it to see something that look like these curved arrows going up. Lastly, focus on CD34 versus CD38. Typically, the stem cells starting where the asterisk, we can see that CD34 positive, but CD38 negative. As the myeloblasts mature into subsequent stages, they start to lose 34 and gain CD38. So in this diagram, if we were to try to make association with something that we know, it somewhat look like number 7. And as you can see in our case example, I kind of see vaguely number 7 as well. So therefore, back to this question, I think we are ready to give me some reaction. Let's see. Reaction should be, I didn't see, okay, see a few thumbs up. Yes, very good. So this is actually intended to be normal myeloblast, which is a regenerative marrow. And you can see that on the dot plots, we see expected maturation pattern. I cannot leave this section without briefly touch base on monocyte maturation. This diagram illustrates monocyte maturation, which in general are started with common granulocyte, monocyte precursor. And as monocyte mature, we can see in the bone marrow predominantly mature form, which is monocyte. When we examine monocytes, typically we can see that similar to granulocytic or neutrophilic maturation, where CD45 also retained throughout the stages of maturation and perhaps upregulated at the final stage of mature monocyte. CD14 and 117 abruptly lost as the monocyte mature, as shown here. However, HLA-DR is very unique to monocyte differentiation, in which in other bone marrow lineages such as neutrophil, megakaryocytes, or erythroid precursors, HLA-DR typically lost as once the cell leaves the stages of precursor. However, you can see here that monocyte population retain HLA-DR throughout the stages of maturation. Now, let's take a look at more mature markers for monocyte. As highlighted here, CD64, CD4, and CD14 typically gain when monocyte matures. And to learn more about acute myeloid leukemia and immature monocytes by flow cytometry, please refer to these two ICCS resources. Next, we are going to talk about B-cell precursors and maturation. Here, our 15-year-old male, he had history of refractory BALL, and note that the MRD or minimal residual disease evaluation positive at the end of induction and also at the end of consolidation. He was therefore referred for CD19 CAR T cell evaluation, and the bone marrow flow cytometry was performed, and note that the bone marrow morphology was negative. Here is flow cytometry analysis. We can see that getting on CD19 positive cells, because again, to put into the clinical context, now we are dealing with a very small population. We try to evaluate whether there are still a positive MRD in this bone marrow. And usually for MRD analysis for BALL, we will be getting on B cell or CD19 positive population. And as you can see here, you can see the shade of the blue, which represents CD19 positive population. So what else do we see here? We see population of CD19 and 10 positive, variable for CD20, also express CD38 at relatively high intensity. Here's another way of looking at 10 versus 45. CD9, there are subpopulation that express CD34 and also CD9 are relatively bright. Heterogeneous for CD58. As you can imagine, this is a case that will help us to understand and learn about B cell maturation. This heat map illustrates how the B cell undergoing maturation within the bone marrow. And just like the myeloid maturation, B cell also undergo maturation in a very consistent and systemic pattern. And in order to orientate everyone here, as you can see, the dot plots that I am going to show will somewhat mimic the color here, in which the most light is stage 1. As the cell mature into stage 2, I will show more darker blue, and then the most dark blue is the stage 3. Keep in mind that the mature B cell will be shown in yellow color. So with that being said, when we look at CD45 versus site scatter, we know that as the hematogon mature into subsequent stages, they gain CD45 as shown here in this diagram and in the dot plot. In contrast, CD10 are decreased as or lost as the B cell mature. By plotting CD45 versus CD10, it will allow us to identify stages of hematogons. As you can see here, when we plot CD10 versus CD45, what I can see here is somewhat, it looked like a steps to me. Next, when we look at CD19, although we know that the B cell precursor express CD19, however, we can see the subtle changes in CD19 as illustrated in this diagram and in this dot plot here, where you can see that as hematogon mature, they gain higher CD19 at stage 2 and then slightly lost CD19. And at the final stage, where you can see mature B cell get it in yellow here, the CD19 is slightly dimmer compared to stage 2 or stage 3 hematogons. And lastly, using CD20 will also allow us to follow the maturation pattern. And that's expected as B cell mature, they should sequentially gain CD20. Therefore, we can see in these dot plots. And to me, when we plot CD20 versus CD10, it's going to look like waterfall here, but some people like to plot it the other way around, which will look more like something where you're going up. So you have to keep that in mind. But this is a dot plot that everyone should be familiar with. What about CD38? We can see here that CD38, as shown here, show slightly increase as B cell mature, but then suddenly show decreased expression at mature B cells stages. And lastly, CD34, as you can appreciate here, CD34 is abruptly lost once the hematogon leaves stage 1 maturation. What are the other markers that we can use for B cell maturation in the bone marrow? We can see that CD19 is bright in the earliest hematogons, and CD58 should show variable expression. But if you ask what is the most helpful 2x2 plot, the expert said that it is CD58 versus 38 and CD10 versus CD20. With that, as you can see, again, on our case, we see the normal maturation pattern represent hematogon. So in order to identify abnormal population, we can see that the red population here, which is now turned on, and it is accounting for about 0.07% of mononuclear cells. We can see that these abnormal population fall outside the expected maturation pattern, and we can appreciate very bright CD10 and also decreased CD38 on the rightmost hand side. Here on the other plots, we can again appreciate that these red population are outside the expected pattern that we would see in the hematogons. And on the CD34 versus CD9, you can see that these abnormal cells do not show CD9 expression, and CD58 is somewhat homogeneous. So the interpretation of our case example is that there was a residual B ALL blast accounting for 0.07% and hematogon 15%. So briefly about hematogon. Hematogon is a normal maturing B cell precursor in the bone marrow and most commonly seen in infants and young adults with decreasing numbers as the patient age. However, we can see increased hematogons in non-neoplastic cytopenias, lymphoma, and in our case, remember we see hematogon of 15%, which is we can see in regenerative marrow following chemotherapy and as well as stem cell transplant. Now, quickly, regarding B cell differentiation in the bone marrow, which of the following is not true? A, CD19 and 22 are expressed without drastic changes in intensity throughout the maturation. B, CD58 shows homogeneous expression pattern. Or C, CD45 increases while CD10 decreases intensity as B cell mature. And with that, before you answer, I would like to give you this diagram again for you to refresh. And if you think there are two answers, but there might be more obvious answer, obvious choices. Okay, so I think we are ready.
Are we doing the clap for A, thumbs up for B?
Yes, same thing, same deal. Thank you for asking for clarification. Clap, thumb up, and smiley face. Can you all re-enter the answer? Because right now I'm confused if it's from the previous questions or for this one. Okay, now it's 9:45. Go. And please re-enter it if you already have. Okay. I see thumb up mostly. Yes. So when we get the right answer, let's move on. Yes, the majority answer B. The intended answer is really B because CD58 should show heterogeneous pattern of expression, not homogeneous. Next question, the purple population shown here most likely represent A, hematogon, or B, residual B lymphoblastic leukemic clone. The context is B-ALL post-bone marrow transplant. I saw that the majority answer A, and before we review the answer, I would like to show that you can see that the purple population actually show the expected maturation pattern, and therefore, yes, this is hematogons. So to learn more about hematogons, I would really fully highly recommend this video from ICCS and ESCCA by Dr. Fiona Craig, and also on the right-hand side, the ICCS educational resources. And for higher level training who would like to learn more about MRD analysis of BALL, please refer to these two resources. Now we are moving to the final part. Since this is the final part, I am giving you two cases back to back. So this is a 4-year-old female, 4-year-old male with history of seizure and CAT scan identified 1 centimeter left thyroid nodule with associated cervical lymphadenopathy. Ultrasound guided biopsy of the left thyroid nodule was performed, and you can see here we see the increased somewhat homogeneous lymphoid population, but they look vary from small to a little bit more medium sizes. Flow cytometry was performed, and we can see from forward scatter and side scatter, the majority of the cells are small sizes. They show heterogeneous CD3 expression with somewhat homogeneous CD45, double positive for CD4 and 8, and with expression of CD3 heterogeneous and CD1A. This population show TDT and cytoplasmic CD3. Case 5, in contrast, 7-year-old female, she has respiratory distress and mediastinal mass, and fine needle aspiration was performed on this mediastinal mass. We can see again the very cellular sample with increased, somewhat homogeneous population of lymphoid cells. Flow cytometry was performed, and we can see that on the forward scatter, the cells from this case probably a little bit larger, but not that much larger. And also, when we take a look at CD5, they are homogeneous. These populations show homogeneously expression for CD5, but also heterogeneous for surface CD3, almost like the previous case. On CD7, we see more homogeneous expression with double positive for CD4 and CD8. And lastly, we can see more homogeneous for CD1A on case number 5. However, this population also show TDT and cytoplasmic CD3 expression. With that, you can assume that now we are going to talk about thymocytes versus T lymphoblastic leukemia/lymphoma. This diagram illustrates T cell maturation, and as we all know that the very earliest precursors start from the bone marrow, and as a cell committed into common lymphoid precursors, they then mature within the thymus. And with that, we can see that at the earliest stages of thymocytes, these cells express TDT, CD34, and CD7 is expressed at the very early stages of T cell maturation. Within the thymus, the first stages is prothymocyte, where we call this population triple negative T cells, which mean that they are negative for surface CD3, CD4, and CD8. As a cell mature within the cortex, so-called cortical thymocyte, this is where double negative T cells differentiate into double positive T cells. And during these stages, you can see also that the cells start to gain surface CD3, and the stages of cortical thymocytes also are positive for CD1A. The last stage within the thymus is medullary thymocytes, where the T cell lost either of CD4 or CD8 to become single CD4 or CD8 positive T cells. With that, so regarding thymocyte versus T lymphoblastic lymphoma, thymocyte typically demonstrate a characteristic maturation spectrum pattern, and most useful are surface CD3, CD4, CD8, and CD1A. As shown in this dot plot, we can see that CD4 versus CD8, the stages of maturation start with double negative CD4, CD8. The thymocyte then gains CD4 and then CD8 to become double positive cells. And at the final stage, they lost either CD4 or 8 to become single positive T cells. We can see that when the cells are gated for surface CD3 negative, which is shown here in yellow population, you can appreciate that we see mostly double negative or double positive T cells. And lastly, as shown in the previous diagram, we expect to see the heterogeneous expression of CD1A as the cell mature into cortical thymocytes and then lost CD1A as the T cells mature into the medullary thymocytes. With that, when we encounter T lymphoblastic leukemia or lymphoma, we will expect a very differentiation pattern for CD, particularly shown here is CD4 and CD8. You can see on the first left, there are tight population of double positive for CD4 and CD8. On the middle, we see the double negative for CD4 and CD8. And lastly, although CD1A seem to be heterogeneous here, but the expected pattern is different from what we see for the normal thymocyte differentiation. So back to our case, now you're going to see that it is gated in such a way that the green population has surface CD3 negative, and the blue is the population where surface CD3 positive. We can now appreciate that the double positive for CD4 and CD8 that are now shown as surface CD3 negative are mostly double positive for CD4 and CD8, whereas the surface CD3 positive cells show either CD4 or CD8 positive T cells. CD1A versus CD3 also show expected pattern of maturation. In contrast, case number 5 show two homogeneous for CD4 and CD8. And also, if you notice, CD4 expression probably a little bit brighter than what we would have liked to be normal thymocyte. And lastly, CD1A show a very homogeneous pattern. So case number 4 is an ectopic intrathyroid thymic tissue. Briefly about thymocytes. Thymocytes, as previously mentioned, this is developing T cell progenitor within the thymus, and we can see that the thymoma, which is the benign or indolent tumor that occur mainly in adults, in our illustrated case, the ectopic thymus again are more common in children and young adults, and the location are typically thyroid or cervical lymph node. And in our case, the nodule is within the thyroid. However, with associated with cervical lymphadenopathy, there was some concern that this could be leukemia lymphoma, and therefore the FNA was performed. As you can already know that case number 5, the diagnosis is T lymphoblastic leukemia / lymphoma. TALL / leukemia / lymphoma are the bloods that committed to T cells lineages, and most are the most form of this type of precursor T cells are mainly as tissue form, which is T lymphoblastic lymphoma. However, they can present as leukemic form, which is T acute lymphoblastic leukemia. And again, this type of lymphoma usually, just like in our case, involve mediastinum, which is the site of T cell development. The flow findings for T lymphoblastic lymphoma / leukemia, typically the cases show CD7 positive and cytoplasmic CD3. They also are often positive for CD2 and CD5, and in general lack surface CD3. In regard to CD4 and CD8, the most common are the double positive, followed by double negative, and then CD4 or CD8 positive. TDT can be expressed in about 90% of the cases, and CD1A can be expressed in about 40% of the case. Now, our final audience participation regarding T cell differentiation. Which of the following is not true? A, the most useful markers to demonstrate maturation are surface CD3, 4, 8, and CD1A. Or B, surface CD3 is expressed throughout the stages of T cell maturation. Or C, metallic thymocytes express either CD4 or CD8 phenotypes. And before we move on, just to refresh our memory. And I think now you are ready to answer. So same thing, clap for A, thumb up for B, and smile for C. Not true. Yes, I see quite a few thumb up, and the intended answer is, if I can move on. So not true. Surface CD3 is expressed not throughout the stages of T cell maturation. It's actually expressed as a T cell mature from double negative to double positive, which is within the cortical thymocyte stage. So finally, you can see that in order to identify abnormal population, we need to know normal. We can identify abnormal by knowing that there are patterns that deviate from normal expected maturation or differentiation. We may see it as abnormal intensity, asynchronous antigen expression, or when the particular type of antigen are either too heterogeneous or too homogeneous. We can also identify abnormal by aberrant antigen expression from other cell lineages. Therefore, an in-depth understanding of flow cytometry findings of normal hematopoiesis will help in the diagnosis of neoplastic diseases and the recognition of reactive diseases. And with that, this is a whirlwind of mature lymphocyte subset, neutrophil differentiation, B cell maturation, and finally, T cells. Thank you for your attention, and also I would like to thank for your engagement during this during audience participation. I'm happy to take any questions that you may have, and I also realize that it's 10 o'clock, so if you need to go. And finally, if you think that your neighbor and your coworkers do a good job, please give some reaction. Thank you for your attention.
Thank you, Dr. Curry. It's very useful for us. It's fun.